call up to the stage now our next presenter, Mr. Jean-Paul Azzi, also from the University of Ottawa.
Hey everyone, my name is Jean-Paul Azzi and I'm an incoming medical student at the University of Ottawa. So today I'll be presenting my project on the validation of a high-risk echocardiogram score for TIA patients. I do not have any disclosures today. Now, just before we begin, what is a TIA, or also a transient ischemic attack? Well, it's going to be a medical emergency, and in about 10% of patients, there's a risk of a subsequent ischemic stroke within 90 days. Now, this is a problem, and therefore, we use echocardiograms to be able to investigate patients with a TIA and to be able to find and maybe identify cardioembolic sources that could have caused it. But the problem with echoes is that they are very limited in their availability in many clinical settings. And so there's sometimes inconsistencies in when patients after TIAs get an echo, where some patients can get an echo at the index visit a couple days later, or even a couple months later. And this is especially a problem because in about half of the patients who do get a subsequent ischemic stroke, this stroke happens within 2 days of them getting their TIA. So if they were, for example, to get an echocardiogram, even a week later, well, the highest risk would have been in the first 2 days. And so there are still questions that have to be answered. For example, do all patients require an echocardiogram? And do some patients can benefit from an expedited echocardiogram? And so what happened in the past was our team, we derived a clinical decision score where we wanted to identify patients who are TIA patients and were likely to have clinically significant findings on their echocardiogram. And so this score had 7 predictor variables and ranged between 0 and 15. But the score was not yet externally validated. So the objective of my current project was to be able to externally validate our validation score in a completely independent TIA cohort to be able to see if we can identify patients that do indeed can benefit from an early echocardiography. And the way we did that was through a prospective multi-center cohort study where we worked in 14 different Canadian emergency departments and enrolled patients who were adults, 18 plus, and also presented with a TIA in the emergency department. We ended up collecting their clinical variables to set up our baseline characteristics and to eventually categorize them within our score. And then we also collected their echocardiogram findings. What we wanted to see was really the clinically significant findings on the echocardiogram. And what we defined as clinically significant was through literature review and expert review, where they came together and defined criterias that really made the patient have a higher risk of their TIA developing into something much worse. And what we also wanted to see was the change in clinical management. Was there something found on the echo that led to the physician changing their management of the TIA? And then we performed a diagnostic performance of our score. And so this is just a flowchart of our study cohort. We had about 5,000 eligible patients, of which about 4,500 were enrolled. Half of those got an echocardiogram, and that was separated between a transthoracic echocardiogram and a transesophageal echocardiogram. And just looking at the baseline characteristics of our study, in the middle column, you'll see the cohort of all of our patients. On the right of that, the patients who got a transthoracic echocardiogram, and on the right column, the patients who did not get an echocardiogram. The mean age was about 69 to 70 years old, and about 47.8% of all of our patients were male. Now, looking at our primary outcome, we wanted to see really the clinically significant findings on the echocardiogram. And what we saw was about 61% of all echocardiograms showed some type of abnormal finding. But this could be something as simple as, for example, valvular calcification, which can even be seen as normal in elderly patients over 65. So what we wanted to see was clinically significant findings. And about 11.6% of all of our echoes did indeed show them, of which 2.1% of all echocardiograms led to a change in management. And these clinically significant findings could have came in different ways. For example, segmental left ventricular echenesis, or for example, a new AFib, or even a large patent foramen ovale. of which there was 2 different ways that change of management occurred through one, surgical intervention. For example, the majority of our cases came through a referral for a PFO closure to the cardiologist, and the other through medical intervention such as administration of DOACs, warfarin, or heparin. And now, looking at a diagnostic performance of our score, so we can see on the left column our score from 0 to 15, and right beside that is all the patients that were categorized and that we gave them their score, and essentially we gave them their score. And so what we see here is in the middle column, the estimated clinically significant finding column. And so essentially what this is the chance of finding a clinically significant finding within each of the respective score. So now, for example, if we look at a score of 6, what we can see is that there's about a 7.6% of patients that have a score of 6 and over, and this correlates to them having about a 23.4% chance of them finding a clinically significant finding on their echocardiograms. Now, what's important to mention is that the score, if patients scored had a score of 0, they would have had about a 6.3% chance of them finding a clinically significant finding on the echocardiogram. And this goes all the way to a 63% chance if patients had a score of 12 or higher. And now, the point of our study was really to be able to prioritize patients to get an echocardiogram if they had a higher chance of finding a clinically significant finding. But we didn't want to exclude any patients. We weren't saying that we shouldn't give an echocardiogram to patients that had a lower score. We just wanted to prioritize the patients that had a greater chance of a clinically significant finding. So for example, this is totally up to resources. Of course, we don't have an unlimited amount of echocardiograms. We only have a specific amount. So for example, if we used a threshold of 3, for example, we would be able to investigate and so give echocardiograms to 42% of all of our patients, but there would be about a 15-ish% chance of a clinically significant finding on those echocardiograms. And so it's totally up to how much resources and how many echoes and staff that can look at these echoes that the hospital has. So it's totally up to the emergency department's discretion. And so, keeping it at a threshold of 6 and over that we can prioritize for the echo, there was a specificity of about 93.6%, and that just means that it's a high specificity, and 93.6% of patients who had a score of lower than 6 did not find a clinically significant finding on their echocardiogram. And so overall, our research and our project went well, but there was a couple of limitations. For example, echocardiograms was not giving to all the patients. And so if we did, in fact, perform echoes on all the patients, we could have found some cardiac abnormalities. We had a low use of TEE since it is invasive, but it would have still showed us some more abnormalities. And finally, we had a variable timing of the echocardiograms, of which some patients could have got an echo right at the index visit, where other patients could have waited a couple of months to get it, and there could have been something that happened within that time period that could have affected our results. And so in conclusion, we did in fact find a subgroup of patients that did indeed benefit from an expedited echocardiography, and that would have been patients with a score of 6 or higher on our score, but of course that could be totally up to the emergency department's discretion onto how much resources they do have and can give echocardiograms to the patients that they can. And then we found out that routine echocardiography after a TIA showed a low of about 11.6%, but also clinically meaningful diagnostic yield, of which if we don't yet have, for example, the TIA etiology, that means the reason why the TIA happened, of our patients, well, in about 11.6% of all of our patients and all of the echocardiograms, we could have found something that was clinically significant enough and that could have given us a reason of why the TIA occurred. So in the future, we want to implement a implementation study that can, in which we can go to see how our score works and if we can really improve patient outcomes and, of course, resource utilization. And so I just wanted to thank everyone who helped me with this study, everyone at the OHRI, for example, Angela, Caroline, and Kathy, and everyone at the 14 different emergency departments. Thank you so much. Is there any questions?
Yeah, we definitely have time for a couple of questions, and just congratulations on this excellent work and on being up on this stage at this very early stage of your career.
Thank you so much.
Congrats. All right. I think I see a question over in the...
Yes.
Hi, John Paul. Thank you for the presentation. It's really impressive work. So I can gather from the research you did, there's some information that can help us prioritize which patients get the echocardiogram fastest. I was wondering about transesophageal versus transthoracic echocardiogram. Do you have any input on maybe would some patients benefit more from the transesophageal versus the transthoracic echocardiogram?
Of course. So a TEE, transesophageal echocardiogram, is also an echocardiogram, but it's just a bit more invasive, in which the probe has to really go inside the esophageal. And that's why we had a lower rate of echocardiograms that were TEEs. And also, it's not really readily available in many hospital settings across Canada. But of course, it does show us a couple more cardiac abnormalities, because since it's really there, and it can really help us with, for example, patent foramen ovalis, and really help us with those bubble studies and Valsalva. So it's really direct, and certainly we can see a bit more cardiac abnormalities. Now, of course, preferably it would have been nice to have all of our patients have a TEE, since it would have given us a clearer view, which is why it was one of our limitations, but it was just the fact that it was invasive that we weren't able to provide it for everyone.
Thank you.
Of course.
Maybe I'll ask a follow-up to that then.
Of course.
In the setting of these resource limitations around access to echo, and especially TEE, was there any thought given to ED-based POCUS?
Yes. We did, in fact, think about POCUS in our study. Now, unfortunately, we did not implement any echocardiograms through POCUS in our study, since really all of our echoes were formal echocardiogram in a cardiology setting, because we really wanted to see these clinically significant findings that a bedside ultrasound would not have shown. For example, something like, once again, a patent foramen ovale could have only been shown sometimes through a bubble study with Valsalva, and that can only be done through a formal echocardiogram. And therefore, POCUS would have helped us in this situation, but what we wanted to see was really the clinically significant finding that POCUS unfortunately could not show us. Thank you.
All right. Well, congratulations again on this great work.
Perfect. Thank you, everyone.